Welcome everyone to the MRCGP SCA Study Club. This is the second session of the study club. So what we're going to do, brief introduction. I think a lot of you were at the first study session last month or have been on one of our courses before, but if you haven't, my name is Muhib Rahman. I'm a portfolio GP and a consultant in medical education. I've held various roles in education and clinical roles over the years. I was involved in piloting the CSA, and our team have been helping doctors get through their membership exams, develop their careers now, coming up to our 20th year. We've trained over 81,000 delegates. Okay, so what we're going to do is we're going to go straight into an interactive role play. I'll then pause and discuss some of the key learning points when we finish the data gathering. We might talk a little bit about then the management and continue the role play for a bit longer. Then we'll revise the key guidance as a review. We'll talk about then other useful resources and support if you need it to pass your SCA, and then there'll be a dedicated Q&A at the end. Okay, so that's the format, how it's all going to work. Let's get straight into showing you the information. Now, remember in the SCA, sometimes there'll be a lot less than this, sometimes there'll be more than this. You get up to 3 minutes to read. Okay, so I'm going to give you a bit of time to read, and then we'll start the role play, and I'll explain how that'll work after you've read. Okay, great. So what we're going to do is we'll paste this information into the chat so that during the role play, you can focus on myself and the simulator. The simulator is actually a part of our faculty. So Masood Rahman from the Core eMedica team will be playing the role. And then after we finish the role play, we'll help to clear questions, right? So the way it's going to work, those of you that joined last time will be familiar, but in case anyone's joining for the first time, we're going to do an interactive role play. So I'm going to be the doctor, but I'm going to ask the questions exactly as you type them into the chat, okay? I'll start with the introduction. After that, listen to what the simulator, the patient, has to say, and then whatever questions you'd like me to ask on your behalf, imagining you're the doctor in the seat, please type it exactly that way in the chat, and then I'll answer it based on that, okay? So have a think about that, and let's get the patient on the line. Hi, is that Reshmi Shah?
Yes.
Hi, my name is Dr. Rahman. I'm one of the GPs here. How can I help today?
The nurse said I should see you about my blood results.
Okay, so whatever you'd like me to ask, please type it into the chat, and then I'll ask it on your behalf, okay? Oh, tell me a bit more about that, please.
I saw the nurse Julie last week, and she said my results were bad and that I should come and talk to you about it.
Okay. Was there anything that you were sort of expecting from your results when you went to that appointment?
Well, I was expecting that they would be bad and that they would make me come and talk to you about it.
Right, okay. And do you know why we do these bloods, why these tests were done?
Because of I think it's for the diabetes.
Yeah, that's right, okay. And you mentioned that you expected that the results would be bad and they'd ask you to come and see me. Why do you think that?
Well, I've had diabetes for 5 years, and that's usually what happens.
Okay. And could you tell me a little bit more about your diabetes, about your control?
Well, I'm not sure it's ever been really under control. So I was diagnosed 5 years ago, and pretty much every time I come and see, every year I come in and have the bloods, and then they tell me they're bad, and they tell me I should be changing things, and they tell me I'm fat. So
And how are you managing with your diabetes yourself?
I don't really know what you mean. I take the medicine.
Like, how do you feel your control is?
I take the medicine. I feel pretty much how I've always felt.
Okay, so you're taking the medicine. I'm sorry to hear that you have those thoughts that you mentioned about your weight. I'm sorry to hear that.
Well, I mean, I am fat, so I'm not upset about it. I'm not a teenager that's crying about it. I know I'm fat, and I've been fat for a long time.
Right. And how's your diet been?
Well, it's up and down. We try things. Well,
Mm.
I saw the dietitian when I was first diagnosed, and that was 5 years ago. And I've tried things with the kids to try and make it better, but I mean, this seems to be where we are.
Okay. And have you had any side effects? You're taking the medication regularly, you said.
Mhm.
Have you had any side effects, any issues with them?
No,
No. Okay. Have you had any thought as to why your control of your diabetes might not be good, why it might be poor?
I think I'm stressed. I know I don't eat the right things. I take my medicine on time. I know I should probably do more exercise.
Okay. And as we're talking about exercise, if we cover a couple of other lifestyle things, do you smoke?
No,
No. Do you drink alcohol?
no.
No. Do you think that your weight might be affecting your diabetes control?
It probably is. They do tell me it does.
Hmm. Okay. And you mentioned that you tried some things with the kids. What things did you try?
I've tried changing some of the things that I cook, and then what happens is they complain about too many chickpeas, too much lettuce, and then they don't eat what I've cooked for them, and then an hour afterwards they're eating crisps.
Right. Okay. And do you think that maybe it might be helpful to have another appointment with the dietitian?
It might be. I mean, I think I'm doing everything I can do. It probably isn't going to hurt to talk to someone again.
All right. And you mentioned that you think you're quite stressed. What's stressing you at the moment?
The cost of living. I have a job. I have 4 children. Just that, really.
Oh, I
I
see.
bet you I wouldn't be stressed if I went on holiday.
Hmm. Okay. Any sort of new symptoms like sweating?
No.
No. Do you feel really tired, fatigued?
I mean, I'm tired, but I've been tired since I had 4 children. I've been tired for the last 10 years.
Right. Okay. And you might remember when you first were told you had diabetes, often people find that they're really thirsty, they're drinking more, they're peeing more. Are you experiencing any of those things again?
I'm probably maybe drinking a bit more than usual recently. But I mean, I work, I'm on my feet, I'm working around, I'm walking around all day. It's
Mm.
quite a hot environment that I work in, so it could just be that.
And what is it that you do for work?
I work in a bakery.
Right. Okay. And do you think that there are any barriers to sort of, improving your diet and maybe doing more exercise?
The cost of food,
Mm.
the time it takes to cook proper food, just having a job with the cost of living, I'm trying to pick up extra shifts.
Mm.
I'm tired.
Okay. And do you find, I mean, you mentioned you work in a bakery, so I can imagine that there'll be a lot of nice treats there. Do you find that you snack or try things as they sort of come out the oven?
I mean, working in the bakery is not helping
Mm.
my diet because there are baked things there, and they do give us food. They give us food allowances. So yeah, I mean, a custard donut is an almost daily thing.
Mm. Okay. And I can appreciate it's difficult with the cost of living, as you mentioned, and finances and so on. Um, have you had any sort of external support? Do you have people around that can help you?
Um, my husband tries to be helpful,
Mm.
um, but I do the cooking. He also has a job, so there's a limit to how much he can help me.
Okay.
We don't really have much family around apart from it, from our own family.
Okay. And you mentioned you've got 4 children. Um, uh, have you got any support with that in terms of, because you said you're working, childcare, is that in hand?
Well, none of them are terribly young, so they go to school, and then one or another of us is at home for them. They're not they're all teenagers.
Okay. And you mentioned that you've had this increased stress. How have you been dealing with that stress?
No, I don't think I do deal with it.
Okay. Right. And what do you think would help you the most in improving, your lifestyle, improving your exercise?
I don't know.
Okay. So can I just check who's at home? You mentioned you got 4 kids and you mentioned a husband.
That's it.
Right. Okay. Right. Okay. Right. Well, would it be okay if we perhaps discuss your blood tests?
Yes, that is what I came for.
Okay. So what they show is that, as you guessed, your diabetes isn't in great control. It also, one of the things you might remember, the nurse also will have done an examination. So she checked your blood pressure, and it looks like your blood pressure. And we also did some blood tests looking at your kidney function, and the kidney function looks okay. That's that's stable. So that's something that's good. Is that sort of in line with what you're expecting? You said that you expected that the diabetes control might not be great.
Yeah.
Okay. And you mentioned that you feel like there's not much else you can do yourself. Would you like support with, for example, getting to a healthier weight?
What does that mean? What does that mean, support? Unless someone wants to come and cook for me in my house, I'm not sure what it is that people, I already know that I'm doing all the wrong things.
Mm.
I really am trying my best. I have a job. I have 4 children. We're barely getting by.
No, I appreciate it. It's difficult. Well, I mean, the kinds of support we could offer is, you mentioned you saw a dietitian before. Sometimes they can, while someone can't come to your house and cook for you, but they might be able to suggest some things that you could change, some things that you could swap for healthy alternatives that you might have thought of yourself, for example.
Yeah, I mean that is what the dietitian did when I first saw them when I was first diagnosed. And like I said, I really did try
Mm.
with some of the recipes that they suggested, and I couldn't get the kids to deal with it, and we just went back to our old patterns.
I see. Okay. Well, I mean, if we look at perhaps your control of your sugars, your diabetes, and your control of your blood pressure, um, given that the control of both of those isn't ideal, how would you feel about maybe changes to your medication to try to improve the control of your diabetes and to get your blood pressure down?
I mean, I feel like I'm already taking a lot of pills. There's 2 in the morning I take for the diabetes. In the evening, I'm taking that metformin again. And then I'm taking the blood pressure one, and then I'm taking the cholesterol one.
Mm.
Just feels like we're going in circles. That I come, you tell me it's bad, I take more medicine, you tell me I'm doing all the wrong things and I'm fat, I take more medication, I come back in 6 months, I come back in a year, and we're just having the same conversation again.
I'm sorry to hear that, you know, that's how you feel about these interactions. Let's try and break that cycle together and, make a change, and hopefully we can get your diabetes under better
If you
control.
can find me some medicines that's going to work.
I'm going to pause it there, and we're going to look through some of the things that are really important in the history and the data gathering, and see if there's anything else that maybe we could find out. Okay, so that up to 3 minutes that you have to read before the patient comes on screen, it's really important that you make use of that time, right? So what do we already know about this patient? They're 47 years old. They've got type 2 diabetes and bilateral diabetic retinopathy. Okay. Well done. Someone asked about if there's any changes to their vision, for example. That could be important, because that could be progression of that. Known to have obesity, known to have hypertension. And you can see she's on a statin, she's on an ACE inhibitor for the blood pressure, and then she's on 2 medications. So that's the second step in the diabetes guidelines of management, because usually you'd start on metformin monotherapy, right? So she's on dual therapy, and then there's an allergy noted here. And then we can see this appointment that she mentioned about a week ago with the nurse. Prior to that, she'd had the bloods done, so we can see that the HbA1c is 66. What do you think about that number? What's the key number at which point we start thinking about adding another medication? Anyone know? Type into the chat. 58. Yeah, well done. Okay. So the 3 key numbers: 48, 53, 58. 48 is both the diagnostic threshold, if you're using HbA1c to diagnose, and also the target if someone's on monotherapy. Like if they're just on metformin, then 48 is what we're aiming for. Okay. 53 is the target if someone's on more than one medication, especially if they're on medications that have an increased risk of hypos, like gliclazide. Okay. So 53 is the target. But let's say they were just at 53 or just over. That doesn't mean you go to the next step. 58 is when we start thinking about going to the next step. And you can see she's well above that, 66. Okay. Cholesterol's okay. EGFR is okay. Using these and LFT is okay. And then as someone picked up, if you look at the blood pressure, the systolic is above target, isn't it? Diastolic's okay, but you only need one of them to be above target, and we want to do something about it. Body mass index confirms that obesity. And you can see that 6 months ago it was 62 and it's progressed to 66. So for some time, she's had poor control and it's actually getting worse. Okay. All right. So key things in the data gathering, what we want to look at is, are they having any symptoms of hypo? So people asked about some of these. So things like sweating, could add to that things like palpitation, dizziness, confusion. Are they having osmotic symptoms of feeling thirsty? And she mentioned that maybe she's actually drinking a bit more and so on, feeling tired. Now she mentioned she feels tired. She's got 4 kids, she's working full time. You could feel tired just because of, things going on in your life. But of course, that can also be a sign that your control isn't great. Okay, passing large amounts of urine. And the complications of diabetes, end organ damage. So the retinopathy can cause visual problems, it can affect your oral health, can impact mood, can cause neuropathies, foot health, important. And one of the things that'd be really important, and someone did ask about it, which didn't have time to go into, but to assess the psychosocial impact, you can see that this patient is really struggling with a lot of things that are out of their control. The cost of living, they're already working full time, they've got 4 children, they're doing what they can. You can see she feels like she's at the end of the tether, okay? And we've picked up that the control of the diabetes is quite poor, right? Okay, so let's start thinking now about how we might manage this, okay? We mentioned about maybe thinking about diabetes medications and thinking about blood pressure medication. So what do you think might be a suitable option? Let's look at the diabetes first. What kind of things might be suitable? Okay, so someone suggested maybe we could go to a glitazone, like pioglitazone, maybe semaglutide. So adding in an SGLT2, someone said, adding in a GLP-1, dapagliflozin, or empagliflozin, right? So good that you're thinking about, clearly we need to go to a next step, right? Because the control has been prolonged period, it's been poor, it's been well above target, okay? Can you think more broadly beyond the diabetes? What other things will be important as part of management? So someone suggests maybe a talking therapy because she's stressed, diet management and weight loss, having an eye check in terms of the retinopathy, see how that's progressing. Exercise on prescription or a health coach. Maybe advice from social prescribers or signposting to Citizens Advice Bureau, because they might be eligible for some financial help that they're not aware of, potentially. Okay. And then what about the hypertension? What kinds of things might we think about? So someone suggested a calcium channel blocker. Maybe someone else has suggested that just maybe looking at the dose of the ramipril. I increase the dose because if I go back, they're on 5 milligrams. So, we could potentially optimize that before we add in another medication. All right. Anything more broadly? Any other thoughts? Okay, someone suggested if she doesn't want to add or change medications, maybe check their blood pressure a bit more regularly and see how that is getting on. All right, so let's look at some of the things that I had down. So, it'd be important to look at maybe giving some structured advice and referring on to help with that weight management. So maybe a dietitian or a weight management program, see what's available. Someone mentioned exercise on prescription. There's actually a lot of areas where sometimes you can, by giving a prescription that, to suggest that someone getting to a healthy weight and exercise as part of that would reduce their risks and improve their health outcomes, then there are, like, for example, like where I am, based in Solihull and Birmingham, for patients in that situation, the council has some gyms that they own where they can get subsidized rate. So, things like that can sometimes help. There are also things that you could suggest that you could get the kids involved in as well. So things like park run are free. There's parks all over the country, and on a weekend you can go and do a 5K. You can walk it if you can't run it. It's quite nice that there's other people. So sometimes that's a way that you can do something that doesn't cost anything. It's totally free to go to that. Something to think about is highlighting the importance of getting the sugars under control and the risks of complications. So she's already got some retinopathy, some of the other risks, so cardiovascular, kidney-related, nerve problems, the importance of screening, so things like foot clinic, checking when they last went to the dentist, and the importance of dental care. We already have an increased risk factor for cardiovascular disease, don't we, in having diabetes that's not well controlled. Patients who then have issues with inflammation in the gums, for example, there's evidence that significantly increases your risk of cardiovascular morbidity and mortality. And then think more broadly, beyond just what they came for and what we've picked up, that because they've got diabetes, there's increased risk. And so things like, did they have the flu jab? To remember to take it, things like getting a COVID booster and so on. Okay, so let's think now about monitoring. Okay, how often should we monitor this patient's HbA1c? Monthly, 3 months, 6 months, once a year? What would be appropriate? Okay, great. So we've got a range. I'd say it's a split between 3 months and 6 months for what most people are saying. So what the NICE guideline recommends is, in someone like this who not well controlled and you can see it's increasing, then every 3 to 6 months until stable. So like I might measure this 3 monthly for the next few months and see what's the trend, especially if we're making changes. Long term, at least every 6 months. Okay, even if someone's stable, then 6 monthly. All right. And so we talked about those numbers. Remember, if someone's on one drug, it's 48. That's the target, especially if they're on something like metformin, which isn't typically associated with hypos. That's also the diagnostic threshold. So it's worth knowing that number. If they're on a drug that's associated with the hypos, or if they're on more than one drug, then the target's 53. But then 58 is the level where we start adding in other medications. Okay. And, when you come up with a target, it's important that you work with the patient, because you want to involve them. If you go for really strict control, remember that there's increased risk of hypos, right? So, what's their tolerance for that? The higher you increase the doses, or if you're adding more medications, there's increased risk of side effects, right? Because each class of drug has their own side effects. So if you're on multiple classes, and then as you increase the dose, slightly larger chance that you might get side effects. The willingness to take, remember, this patient made it clear she's happy to swap a tablet, swap one of the treatment options, but she's fed up of taking so many tablets. She doesn't want to take more tablets. You've got to take that on board, because there's no point prescribing something that someone's not going to take. Do you see? If they're not going to be compliant, it's just not going to work. And you want to think about, other health issues, their quality of life concerns, their overall health. Okay. And so you might have seen the NICE guideline, NG28 is the relevant guideline for the latest one for diabetes. But they've got this quite helpful patient decision aid. You can use this in that discussion with the patient, that what's a good target for you, so you can individualize it. Okay. Some patients, if they work in a job, she mentioned works in a bakery, for example, potentially, if you're working around a very hot oven, having a hypo might be a big problem for you. If someone's working, in a warehouse where they're operating a forklift truck and they have a hypo and sort of feel a bit sleepy, that could be really, really risky, right? So, how important is that to you? If having a hypo would be a big problem, then, maybe you relax and have a higher HbA1c target. If they're worried about side effects of medications, then, maybe Again, a higher target rather than stricter control. If they're not so concerned about that, you can go for a lower target. Are they willing to take more medications? Do they have other health issues that increase their risk? And then in this patient is quite young, but if you had an older patient, you might think about multimorbidity, other medications, interactions, and so on. So let's go through then the guideline and the steps so that it's clear in everyone's mind, and then we'll wrap this up. So, it's important that they understand that we probably do need to do something. I think that was a really nice thing that someone put into the chat, that let's break this cycle together. That was a really, really nice way to put it, because you can see she's fed up and she feels like we're going in circles. So let's break that cycle together, very person-centered, involve them, and hopefully we can improve your control, and then it doesn't feel like this, like you're just going around in circles. Okay. So, do they want injections? Are they happy to have them? Concerns about weight gain? And then we've also got the issue about hypertension. You can see, so we've got two options with hypertension. You could increase the ramipril. You could add in another drug. What could you add at that step? You could add in either a thiazide-like diuretic, or you could add in a calcium channel blocker at the next step. Given she doesn't want to have more tablets, do you see why for this patient it'd probably be better to try to optimize the dose of the ramipril, take that to 10 milligrams before you add in the second drug? Okay. Now, if you do that, remember it's important to check renal function 1 to 2 weeks after, and then recheck the blood pressure about a month later, about 4 weeks later, to give it enough chance to work. So let's go through the steps in terms of what would normally be the next step. So normally the next step would be triple therapy. You'd normally be adding in a third option. So which one you add, actually the guidance doesn't say that it should be this or this. You could add any of the classes. You could add in a gliptin, a DPP4 inhibitor. That's not associated with weight gain, reduces the risk of hypos compared to, say, sulfonylureas, all right? Gliclazide, glibenclamide, she's already on one of those, right? You could think about pioglitazone, but actually, given she's already obese and she's got concerns about weight, there is some evidence that glitazones are associated with weight gain. So that might not be a good option for this patient. And then SGLT2 inhibitors, so gliflozin. These might actually promote weight loss, slightly lower risk of hypos and sulfonylureas. For this particular patient, probably the best option would be to swap the gliclazide, so stop the sulfonylurea, and change it over to an SGLT2 inhibitor to both reduce her cardiovascular risk, and it may promote weight loss. She said that she didn't want to take additional tablets, but would be happy to swap one. So, we could think about some of these things. Okay, and then in terms of relating to others, really nice things people put in the chat, the importance of being supportive, picking up on some of those cues. You could see she's fed up. She mentioned stress. We picked up and explored that cue. That's how the scripts work in the exam. They will drop in a cue. If you don't explore it, you might not find out something important there. She mentioned about her work. Finding out about that, you can see the relevance, given she's got diabetes, poor control, being in a bakery, lots of sweet things, lots of things calorie dense, okay? It's very tempting, okay? Concerns about the weight gain, addressing misconceptions. So thinking that she might put on weight with any other medication, or that the only other injection option will be insulin. And then involving the patient. So having a shared decision-making process, that once they know the options, you can discuss the pros and cons, and then you can take on board their preferences. Okay, good. So well done. Really, I want to talk a little bit then about other forms of support that we can offer if you'd like it. So this case was adapted from one of the cases in our MRCGP SCA casebook and our SCA cases online. Those have similar cases. They will eventually be harmonized, so they have the same cases. At the moment, the casebook has got a full mock. The SCA cases online don't have that, so there's slightly more cases in the book. The book looks like this, okay? Our team worked really hard. We're really proud of it. It's got 400 pages, 75 cases, all 12 domains of it, including a full mock, and each one has a detailed, it's got a doctor's sheet just like the real exam. It's got a very detailed script for whoever's going to be the simulator. So the scripts normally run into a few pages, a couple of pages, and then most importantly, specific detailed mark scheme with key learning and links for further learning, okay, after you've gone through it. So, excellent to use in a study group, and it was the first casebook published dedicated with specific mark schemes for the SCA, because remember, SCA marking is different to both CSA and RCA. Both of those, diagnosis was marked as part of the management domain, data gathering was one of the domains, and then interpersonal was one of the domains, and all three domains were weighted equally in the RCA and the CSA. In the SCA, diagnosis is part of the data gathering domain marking. So it's data gathering and diagnosis. And then management and complexity is worth 50% more than the other two domains. And the interpersonal skills is broadened to include other things as part of relating to others. So the mark schemes in our book and on our SCA cases online are mapped to the new SCA marking, okay? And then the online version, same cases, hasn't got all of them. They will be added shortly, but it's also got a couple of examples of high scoring or high quality consultations in terms of key skills and an overview of the exam and how to approach it, okay? But the actual cases are drawn from the same pool. Then our GP 100 case crammer is very different. So the SCA cases are to use, to study, to practice with others. The GP 100 case crammer you can use on your own if you want to consolidate the knowledge. So we cover 100 cases in blocks of 5. Every fifth one's an interactive case like we've just gone through. There's a simulator there. But the others I talk through. For example, case number 1, I'll talk through what are the key things to ask in the history, what examinations to think about, because not just for the exam, it's for everyday consulting. You know, I demonstrate some of the examinations, how to do the pull test, for example, okay? And then what are the current guidelines for management, key red flags not to miss, how to explain things, examples of explaining things clearly and concisely and confidently. So there's 100 cases, okay? All of these are covered. And then if you want actual practice, actually just yesterday from this very room, we had our last interactive SCA course, our full day course. We do 20 live role plays. We have professional male and female simulator, so male simulator, female simulator. There's myself and another faculty member to examine and give feedback. And it means that you get to see lots of cases. You get to see other people getting feedback, but you will also get to get involved in an interactive case in the morning and then later on do a full mock case with detailed individual feedback. So you have a really clear idea, exactly what do I need to work on, okay? So we do 20, it's an intense course from 9:15 to 6:15, it's a long day. So the next one is the 9th of January. And you can find details, we'll post a link for you there. That's the next live session. Is the 9th of January. You also get pre-course learning before, and it includes access to all of these cases afterwards. There are options to also add this in, to also add in one-to-one coaching afterwards. There are different bundles available. You'll see them on the page, okay? So that's the end of the talk session. For anyone that hasn't got questions, I hope you found it helpful today. The recording will be available, as I mentioned, by early next week. And I hope to see you for the next one. We'll post the date shortly, both on our website and also into the Facebook group. I'll just show you on our website where you'll find it. So if you go on our website, first of all, everything to do with SCA is here. So you've got like our intensive course, we've got the Pass the SCA bundle, the case book, you can get all kinds of things there. But if you go back to the home page, at the bottom, we have our next events coming up, okay? So like, for example, this weekend, we've got our full day AKT preparation course. Our pass guarantee program for April is starting the 5-month program. As you can see when the next course is. So once we've got a date for the next session, you'll see it here. And some of you might have joined our recent GP update. We're also running one of those every couple of months. Watch out for the next one of those. That covers a clinical update and some practical consulting tips, okay? So for anyone that hasn't got any questions, thank you so much. Hope you found it helpful. I do hope to see you at the next one. Keep up your hard work, prepare, and you will succeed.